You can go ahead, Bill.
Oh, thank you. Okay. Well, welcome back. I think our conference is off to a great start, obviously, judging by the commentary and the chat and the Q&A. And we're going to move now to Lailea Noel's presentation. Lailea is an assistant professor at the Steve Hicks School of Social Work at the University of Texas at Austin. Dr. Noel holds a courtesy appointment as assistant professor of oncology and health social work, co-chairs the Health Equity and Research Work Group, and serves on the Livestrong Cancer Institute's Clinical and Prevention Research Work Group at the Dell Medical School at UT. Dr. Noel is a health equity scholar with the American Psychosocial Oncology Society and director-elect of the Diversity, Equity, and Inclusion Committee of the Association of Oncology Social Work. Dr. Noel has an extensive practice background with 20 years of health administration experience in the field of oncology and nonprofit management. Her research interests seeks to connect communities most impacted by cancer disparities with cancer care services. She has a wealth of experience engaging communities, social scientists, and medical professionals in such research pursuits. I'm proud to introduce Dr. Lailea Noel.
Thank you, Bill. I just have to. Thank you so much for having me. It's an honor to be invited to present to this group. I'm going to, oops. Okay. So it was interesting that actually Terry ended her Q&A session with a comment that was along the lines of, we need to work with communities. We need to broaden the conversation to include the community and then have a plan. And I mentioned that because that is exactly what I'm going to talk about. So actually it went, it was a nice segue into my conversation. So we've talked a lot today about the patient side and the provider side and what some of the disparities are. My conversation for the next 30 minutes will be how do we include the community and the community voice at this table? How do we make sure that we are actually listening to communities, that we're asking communities what they need and actually including them as part of the solution? So I'm also going to start with some voices from the community, similar to my colleagues. This is one of the voices from one of the qualitative studies that I did. This participant said, "I have worked really hard to make sure my boys are not caught up in what's happening out there. You know what I mean? They are in school and doing well. If I'm too sick to keep up with them, who else will? I just don't know." Another person, it's hard for me to see this with all the, I'm with Terry now. I'll use my other slides. "I thought it might have been stress and all that I had to deal with on a daily basis. I knew it was something, but I never thought it was cancer. They wanted to know from me, how could you take a bath every day and not notice that you had tumors protruding through your skin? I said, my kids are fed and clean every day. I get them to school on time. My house is clean. I take care of my grandmother and I work full time. I was able to pay my bills and take care of my kids. By the time I got in the bathroom to take a bath, it would be after 10 o'clock. I would jump in, shower, and literally almost pass out, being so tired because I worked full time. So I didn't pay any attention to my own health because I was responsible for 4 other people." You may wonder why I mention these. Well, I mention these because these are real people who are dealing with real issues in their community and in their environment that delays their chances of connecting with psychosocial assistance and other patient supportive services that they need at the time during their cancer care journey. You've already heard from the colleagues earlier what health equity is, but I'll just quickly revisit this because it's been a little while in case there's new people who have joined us. Health equity means that everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health such as poverty, discrimination, and their consequences, including powerlessness and the lack of access to good jobs and fair pay, quality education, housing, safe environments, and healthcare. We often think that that equity is equal to equality. And you've already sort of heard a lot about why that in the first half of this workshop as to why that's not the case. This graphic just sort of lays out the differences between equality, equity, and justice. And what I appreciate about this is that when you start to think about equity and justice, you start to include the community, you start to include the system around the patient. And what's interesting is that even if you were to give someone, like in the equity picture, let's say you give them a bag and a ladder that actually gets them up there, there's still not a whole lot of apples on that side of the tree. So part of the problem is not just that we provided communities with, access to pain medication or more pharmacy, we've given them, they have access to providers, but there's not enough pharmacies for them to actually access to get the medications that they need. You've heard a lot about this from Dr. Smith and Terry, so I won't belabor that point, but the idea is just that there needs to be more work done to provide more, not just access, but services and opportunity and actually pain medications. So what does this mean from a community perspective? So a lot of times when I hold meetings with communities and with providers, we look at and we discuss issues around social relationships, neighborhood issues, institutional issues, and also upstream factors such as culture, language, and other sort of cultural norms. You've heard a lot today about healthcare systems issues. I want to talk to you a little bit about the community. So I'm going to actually use an example from my work with rural communities in Texas to sort of lay out what I've heard from the community about the needs of accessing services. So just to give you a little bit of background, 20% of the US lives in rural communities. In Texas, 27% of Texans live in rural communities, which is about 7.6 million Texans. We have 254 counties in the state of Texas. 233 of those counties are designated as rural, which means that 7.6 million people are spread out across 233 counties. 23 out of the 30 counties that are within the actually service area of the University of Texas at Austin and Dell Medical School are considered rural. Rural Texans travel nearly 3 times longer than urban residents to access medical services. Rural residents experience comorbid conditions, yet in comparison to urban areas, rural communities have fewer numbers of residents covered by employer-sponsored health insurance. Approximately 3% of medical oncologists provide on-site care to rural areas. And again, remember 7.6 million people spread out across 233 counties. And less than 3% of medical oncologists are present. Rural communities also face disparities in social determinants, such as housing insecurities, food insecurities, financial toxicity, and the inability to afford medication to treat the side effects of medical treatments and medicines for coexisting healthcare conditions. Rural cancer survivors experience lower mental health functioning and more significant anxiety and depression and distress and emotional problems than their urban counterparts. Yet, only 2% of health social workers practice in rural communities, with very few, if any, who specialize in oncology. So what does this look like when we think about interventions and including the community in conversations? one of the models that I like to present when I talk about this is that we would love to be able to provide kind of like a synergy and empowerment situations for our cancer survivors in different areas, such as social determinants of health and mental health services and access to care and access to cancer care, so social cancer care services. However, because these are all linked, if there was a higher presence of social determinants of health, then we know that that's going to pull on people's access to mental health services. If there's more of a presence of social isolation, again, spread out over 233 counties, we also know that it's going to have a ripple effect, probably more social determinants and less access to mental health services. So what do we do about that? The work that I do, which is called group model building, is a process of engaging stakeholders to foster learning about the complexity of these problems and to decide on a course of action through a consensus. And this includes bringing to the table academics, the community, and practitioners to engage in these conversations and to create plans. The upside of using group model building is that we can get below the surface. We can start to look at what are some of the patterns of events that we see in communities. What are some of those system structures that are in place that are posing barriers to care and service delivery? And we can also look at some of the values that are influencing these systems and the connections within the systems. With the group model building that I've done, where I've brought academics, community, and practitioners to the table to have conversations, we seek to identify current community assets important to connecting rural Texans with care, identifying gaps in existing community assets, identifying barriers to connecting the community to services, identifying breaks in services we haven't thought about before, share places where care has been received and times where care has been needed and perhaps delayed. And I might mention here too, when we say bring everyone to the table, we actually meet in the community in a neutral spot, because we're not actually inviting the community to our table, but we want to meet them at a new table, a table where everybody hopefully has more of a shared voice at that table, and everyone feels equal. And it's not like we have all the solutions, so we want to give that to you, but instead we recognize the fact that the community are experts of their community, and we want to hear from them. We want to listen in. We want to talk to them, not just talk at them. So I just want to share a few results. Sure, monitor my time, from some of the regional conversations, and then the Texas rural sort of findings that I found. And I will mention that we actually drove around to the 7 different regions of Texas. And if anyone is on this call who's from Texas, you will know that Texas is huge and all the regions are extremely different. And so I mentioned that just to note that it's not a one size fits all model. It's going to depend on the community that you're working with. And it's going to be really important that we build presence and build trust in order to have these conversations, because a lot of people have not been asked to these tables before, or if they have, it's been broken relationships. And so there is some healing that needs to be done before we can actually have genuine and vulnerable conversations with communities. But that being said, a lot of the regions in the state of Texas, there were some common themes, and I think those common themes are things that can be useful in the arena of pain management. So in one of the regions, they talk a lot about what are some of the solutions, or what do we need as a community to actually provide better services to cancer survivors. And so some of the common themes that came up were reallocating the funding for more services. And so it wasn't that the community wasn't saying we needed more funding. It was saying that the way the funds were sent to the community for example, transportation or providing how much medication someone can access, how many pharmacies are available. The way the funds were allocated by county, did not match the need of the county. And so they were asking if they could actually determine how those funds would be reallocated within their community based on the unique needs of that community. Also, continuity of care and care coordination. You heard a little bit about that from Dr. Smith and Terry, that there needed to be more of this continuity between care. And so I neglected to mention that the people that were at the table included mental health providers, representatives from the sheriff's department, representatives from the emergency rooms at the local hospitals, and community members. And so a lot of the conversation was like there needed to be more communication and more continuity of care across provider and community-based facilities. Another region talked about integrative care, building more community partnerships, building on the strengths of community partnerships. Of course, there was conversation about increased staffing. That was sort of something that was across several of the regions as well, expanding mental health workforce, providing more providers in communities, looking at communicating in a language of the customer, meaning that not just, again, not dictating to communities, but actually trying to increase health literacy by actually utilizing the language of the community. We're not just talking about whether we're talking about Spanish or English language, we're talking about actually understanding how people need to receive the information, in what ways, and then also providing that information through those vehicles. Another region talked about, again, you see some common themes going through: more flexible funding, well-paid, diverse workforce, building more community partnerships, increased pool of providers. Again, those are all like common themes that were across several of the regions. Telecommunications came up as a big deal, and also this was pre-COVID, so became even a bigger deal post-COVID. And then other groups talked about data, data sharing, again, collaborating, stigma reduction around, I think Dr. Smith and Terry talked a lot about stigma. The community was also talking about stigma reduction and how can we address that? What are the plans to addressing that? Some of the plans that they talked about were talking about it a bit more in the community, and having more town halls, or being able to work with some of the local media, especially the media that were focused on African Americans and Hispanic Americans, that were more targeted media, so that we can have more conversations about it and destigmatize the use of opioids. A one-stop shop accessibility, so I don't have to go, we mentioned earlier that someone has to travel upwards of 3 hours to get to services. And those services are generally not all, like they have to go to different places. So the community mentioned having one-stop shop accessibility. Again, I think that goes back to continuity of care services as well, and being able to bridge relationships with community organizations that can also help. So then I just want to, I think all of it this region I think summed up a lot, where they were saying like there's collaborative relationships, which leads to decreasing social drivers of health, which leads to better crisis services, which leads to hopefully less staff shortages, greater access to care, and then finally, how all of us are in this together to help our clients reach self-sufficiency and well-being. So then just to highlight a little bit about across the state of Texas, like I think a lot of times people want to know, well, what do we do about this? What are the plans? How do we make this into something that's actually useful and actually pushing the needle forward on decreasing inequity and increasing health equity? And so what we asked from these various regional groups is, what do you think could be done? And what I want to highlight is the ones where 5 or 6 of the regions mentioned items, because I think these are items that have teeth. These are items where we can actually get in and make a difference as with community, academic partner, and practice partnerships, by way of providing crisis respite, more support, integrative care, lobbying and advocacy work, which you're going to hear about next, access to care, community agency collaborations, comprehensive service array, meaning from youth through adult, housing, more safe, affordable, and sheltered, and more housings and more shelters, and improving telehealth and connectivity and infrastructure. These were things that would lead to better access to care, better coordination of care, better coordination between social drivers of health and mental health services, as well as including the community in the solution. And we all know that if we include the community in the solution, we have a better chance of sustainable solution outcomes. So the implications, this type of work allows us to build bridges. We should collaborate more with mental health and community leaders. We could do more modeling sessions of care, or sessions where we model care delivery in socially isolated communities throughout rural areas, as well as urban areas that you're working in. Engage in community asset building and empowering and equipping communities to be self-sustaining and to feel as if they actually can make a difference in their communities. Explore the impact of these system ties on socially isolated communities. And then finally, I just want to leave you with this. I really like this quote that I heard recently that said, "Their voice is so quiet, I'm compelled to lean in." The reason that I like that is because communities are not necessarily going to come at us and sort of knock down our doors. But if we listen very closely to what they have to say, we can learn a lot. And that partnership can take us far. If we work really hard to build these systems that are collaborative, we can knock down some of these walls of inequity and move us closer to a more equitable service delivery system. Thank you.
Thank you very much, Lailea. That was an excellent talk. Lailea, a couple questions have come in, which I was hoping you could address. One is, what are the optimal outcomes for engaging communities experiencing health inequities?
So I think that one of the most important outcomes is that if we are this concept of sustainable interventions, I think that if we include communities at the table from the very beginning, we have a better chance of communities adopting the interventions that we put in place, or any of the changes that we may have incorporated either within practice or within communities. If people's voices are included, and if we are actually listening and we're actually learning and we're developing our interventions based on the tailored need of that particular community, then I believe that we will have more sustainable interventions. I think another outcome would be increased trust. The more we have conversations with community, the more we include their voice, the more we listen and then we respond appropriately, the more we'll be able to break down some of the trust barriers. And I think Terry said a lot of this earlier, that we have to talk about trust. We have to talk about history. We have to we can't ignore it. We have to include it as part of the conversation. So I think by engaging communities, we learn as providers, we would learn what some of those historical trauma events are in order to address those and move forward.
Okay. And you've partially answered this next question a little bit already, but I'll ask it anyway. It's, am I able to build trust with communities as a white oncology professional?
Yes, definitely. And I'm really glad that you asked that question, Bill, because often when I'm presenting, a lot of people are like, but I don't look like the community. Is it going to be very difficult for me to build trust? And I respond by saying, I just have to say this to I teach social work students, health social work students, and I say the same thing. It's like, I can't even walk into a community of Black cancer survivors and expect to build trust immediately. Trust comes from relationship building. And so the more time that we spend building relationships and showing people that we're going to show up and we're going to keep showing up and that we want to be there and that we want to partner with them to help make a difference, not be savior, but to actually be a part of the solution. I think people will start to get that, okay, we mean that we really want to do this. And we may start with other things that are outside of cancer. Like when I worked in St. Louis, we started with helping the kids in the neighborhood with learning how to ride their bikes safely by providing bike helmets and working with parents and helping to create safe walking paths for community. But showing up and being a part of the process makes a difference. The second thing I would say is partnering with the community. Finding those key informants within the community is important. We all have to do that. And even I would have to do that. Those are the people that are going to make the difference because they already have the trust with the community. And our role is to identify who those people are and to work with them in order to help advance the needs of the community.
Okay. And one more. The question is, who are the stakeholders that need to be at the table for this kind of work?
Great. So I would say that you want to make sure that you have every member of the system that you can think of at the table. So that would be the providers, the social workers, the nonprofit leaders in the community, the faith-based community, the various, even if the auntie on the corner provides a lot of the health kind of that, what do you call it? I'm thinking of the word so there's, I can't think, but anyway, she provides a lot of information to the community. Like a lot of people trust her. And so they go to her when they have questions. We want to include her. We want to include stakeholders that care about the community, that want to be a part of the community, that are a part of the community at the table so that we have all the voices we can think of sharing their perspectives so we can get a bigger piece of that pie. Let's underneath that iceberg, those patterns that we don't always hear about when we're just conducting our research and not really including the voices from the community.
And I don't see any more actual questions, but there are a lot of comments related to the agreement with you on the importance of relationship building.
Good.
And transparency and honesty.
Yes, definitely. Absolutely.
And there's appreciation for addressing the issues that rural communities have. It is difficult for people to understand the challenges. And the one last comment is, I love you saying, not be a savior, but be a part of the solution.
Definitely.
It is a good reminder that we are not saviors, but are here to empower our patients and clients in our community.
Yeah, I heard someone say the other day that about that communities don't need to be saved; they need to be respected and heard and then partnered with in order to advance the issues that are important to them and to us as part of that community.
Okay.
Thank you.
Thank you, Lailea. Really appreciated your talk.